Hello, hi everyone. Good morning, good evening, good afternoon, depending on which part of the world are you joining from. Today we are delighted to have a guest from Cameroon who is a rising star. He's being honored with Sabin's Rising Star Award for vaccine equity because he's demonstrated it is possible to identify zero dose children and reach them. And it's my pleasure to have this conversation with Dr. Clovis and welcome him here in Sabin studio. Welcome, Dr. Clovis.
Thank you so much, Anuradha.
So it's great to have you with us because at Sabin, we are very interested in understanding the perspective and the point of view and the experiences of immunization professionals who are working on the ground to make things happen. So, Dr. Clovis, the first thing that I really want to understand is how did you start to believe in this whole concept of zero dose children, something that I am very passionate about, having created this concept, and what exactly did you do in order to identify and reach these zero dose children who had been missing the most essential life-saving immunizations for God knows how long?
Wow, that's a very interesting question. Actually, it's been not just a one-time thing, that happened and I understood that, okay, zero dose children should be a priority. It's just a series of so many events. For instance, you move into a community and you realize that the women give birth at home, which means the children technically miss out on, the first doses of vaccines, which of course, as we all know, when a child has access to the first dose, there's an increased chance that they can have access to the other doses. So at that time, the concept of zero dose was not known per se. So what I knew was these children were unimmunized and that was it. But in 2019, Clinton Health Access Initiative did an interesting survey across 6 districts. And just in those 6 districts, we had over 1,000 unimmunized children, right? So at this time, we're still not calling it zero dose at all, but we knew that there were over 1,000 children in such a few communities that, were unvaccinated. And this was inspiring because it meant that probably in other regions, there are these kind of communities that have clusters of zero dose children, which we have been missing all along, and these communities miss out not just on vaccination, but also on other primary healthcare services. So if you were to find out a community where maybe 40% of women give birth at home, then you are most likely to have, clusters of zero dose children. So that was just how it all progressed to this stage.
Wonderful. So you actually said a couple of things which are so important for everybody to remember. One is that with the unvaccinated children, which we now call zero dose children, or under vaccinated children, they actually remain very powerful symbols of gaps in immunization. But more importantly, they represent those families and households that are deprived of several other health services. For example, the mothers of these children often do not have access to skilled birth attendants, as you said, and therefore end up delivering at home, which really means that women in those households are bereft of essential services, and then the children also at much higher risk of not receiving immunization, but also other services. So, Dr. Clovis, tell us, what did you do exactly to make sure that these children received their vaccination and that these households and families actually had much stronger health-seeking behavior?
We realized one thing. These communities, they know what vaccines are. They would have loved to have vaccines, but they have other issues that turn to, serve as a barrier, between their children actually having access to these vaccines. And the most common is maybe you go to a community where, there's a lot of malaria cases and malnutrition. So that is their priority. Now, when you move into this community and the first thing you're offering is vaccines, they will resist, because the impression is, if we cannot have access to food, we cannot have access to other things, and you are bringing us vaccines, then there is something wrong with the vaccines. So that trust gets eroded. So what happens is, when we approach this community from the perspective of, oh, we are coming to help them, or we are coming to solve their problem with vaccines, it just doesn't work. So to make this work, we started off by setting up what we called a micro facility. And that micro facility was to offer a basic health package that constituted what the community considers as their priority. So when this was done, it became easier now for, the population to gradually warm up, to vaccination services, because they could now ask, because they know that, okay, when I go to this facility, if my child is sick, they are going to take care of my child. And then they become even closer to, the healthcare worker. The other approach, which I found very interesting, had to do with the use of community-oriented primary care model, in which you go to a community where there is no health facility, but they have community health workers, and where they don't have, you build one with the community. And then you use this model to sample opinions and understand which health needs that community really needs. And then you put up a package that suits community health workers. And then through that, community health workers, while offering these packages, are able to refer patients for vaccination. So these kind of integrated approaches have proven to really work quite well. And that's mostly what we do.
So this is very insightful, Dr. Clovis, because one of the very important aspects of Sabin's new Brave and Bold strategy is the E in Brave. And that E is all about enhancing integration, because we acknowledge that unless we provide an integrated package of services to communities most in need of healthcare, there just won't be any acceptance of standalone interventions. So you really echoed that by saying that when only vaccines are taken to these communities, which have multiple other healthcare needs, which from their perspective might at times be even more vital, then not paying attention to those needs and continuing to follow a health intervention like vaccination in isolation can actually be counterproductive. And therefore, understanding communities' felt needs and trying to provide an integrated healthcare package is really the best way forward, because it is then useful for vaccination, but it's really useful for communities, because it is then an opportunity to respond to their needs much more holistically. So let me ask you another related question, and that is about HPV vaccine. You spoke about mistrust or lack of trust on the part of communities, and making sure that we offer a broader package of services to communities to really establish that trust between health institutions and people. What about human papillomavirus vaccine? Cameroon is one of those countries that introduced the vaccine in their public health program, and yet coverage of this vaccine has been quite low. What do you think are the drivers of this low uptake of a vaccine which is highly effective?
What is critical about vaccines, or the error we make most times, is because we think that is, or we know, of course, that is very effective. And so we assume because of that, people should just accept. And that is where the problem begins. I think COVID-19 with all the ill luck that it brought, also came to give a little bit more light on, how we all can react to vaccines when we don't understand, because we're faced with a situation where even healthcare workers were refusing vaccines. So this is the same thing with HPV. It's easy for us to understand because we read the research work, we see how it's working, but for them, it's complicated. Explaining to a family that we're going to vaccinate just your female child that is 9 years old is complicated because they think, okay, they are going to sterilize their child. Their child will never give birth again. They are trying to control the mind of girls, to think and behave differently, and so on and so forth. It becomes very, very complicated. So I think the most difficult part of the HPV vaccine rollout is that most institutions do not invest in the communication part. So they are more interested in the service delivery and then leave out, the communication aspect. There is no, they assume the traditional approach to vaccinating children that it will just automatically work for HPV. No one really sits to design an approach, run a pilot with a small population, see whether this works, use tools like behavioral and social drivers to see exactly where barriers can come in, and then work with some of these communities to actually roll it out gradually. For instance, in Cameroon, when it started, the communication was more or less like, we do during campaigns, you have door to door and so on and so forth, but it is not, sufficient. So those are the critical challenges that has to do with HPV. If we can invest a little bit more on communication, then we begin to see some of the results, and not just investing in communication, but also community engagement. How do you get the pastor or the village chief or the imam or religious leaders? How do you get their own consent? Because if the Catholic team in Cameroon at one time were against HPV, so if their voice is not properly captured at national level, if the bishop says no vaccination, it stays that way no matter what you do. So those were the main challenges or drivers that we could pick out.
So, Dr. Clovis, a lot of good insights there. First, your statement that HPV is not a traditional vaccine. So it's not a vaccine like any other vaccine or any other childhood vaccine, because it's being given to girls who are 9 years old. And the second issue you raised was only girls. Vaccination can also be perceived differently, particularly for a disease which is sexually transmitted and can very quickly give rise to a lot of misperceptions, rumors, and suspicion. And then really finally, this whole critical issue of investing adequately in communication, but also community engagement with very sharp focus on engaging with leaders and opinion makers, particularly religious leaders. So let's just take this conversation forward to understand what really are some of the solutions around HPV vaccination. Do you think that linking HPV vaccination with cervical cancer can actually help communities understand the value of this vaccine in saving the lives of women who actually die in the prime of their youth because of HPV-linked cervical cancer?
When it comes to HPV, there are a number of things that must go together. When we try to isolate it, that we just want to vaccinate girl children, and it becomes a problem. And that's why I'm very happy, because of recent, the Ministry of Public Health has now included the male child. So it solves some of the barriers that had to do with gender, saying, okay, they have problems with girls and so on. So this is already something positive. Now, the other aspect, which is very important, is being able to look at treatment, screening and treatment for cervical cancer. If I come to vaccinate your child and I'm also coming to screen you, you will be more comfortable with me vaccinating your child. So the approach that I think that is best, that should be used, should be integrated. If the team is going out there to vaccinate, there should be services for screening of mothers and then vaccinating the children. That's the first thing. The second thing has to do with how do we communicate? We assume that this thing is easy. It's actually very difficult to understand why you vaccinate, just the girl child, and then suddenly you say you want to start vaccinating male and female child. And so it's very difficult to understand. But if we can use other approaches, not to scare people with images, but there are communication experts that can sit, evaluate, understand proper use of images to convey messages, the use of community health workers to drive stories around cervical cancer, using stories people can relate to, do a little bit more of storytelling, understand people, take some time to understand how people live. Because when we live from the city and then we come to these villages, presenting ourselves like saviors, coming to save them from cervical cancer, it's very difficult for them to have a clear picture of what exactly we want to do. But if we come in, we have this kind of partnership that is very inclusive, which means you make sure religious bodies are represented, the different clans or traditional heads or families are represented, women, young youths, and so on. When we have, or even people living with disability, making sure everyone is fully represented. And then you set up a dialogue structure that has a feedback loop, which means that if I said I have a problem with HPV vaccine because of the side effect, how can I report this in a way that nobody knows that I did the reporting? How do I communicate with those vaccinating? How can I cry foul that, okay, my child that was vaccinated had this problem? If there is this guarantee of this kind of feedback loop, and then the community leaders are fully involved in the decision making when it comes to offering these vaccines, which means they're the ones that mobilize their community. They're the ones that say, no, look, we cannot vaccinate today. Let's do it next week. When we get to this stage, the confidence gradually sets in. The next group of people which we ignore are the schools. This has to start from top, from the Ministry of Basic Education, collaborating with Ministry of Health, agreeing that this is something that can be done in a school milieu, and then moving right down, to operational levels, establishing a clear pathway. How do you vaccinate a child in a school with the parents' consent? What is the processes? How do you ensure this parent is okay with this vaccination? If we use those approaches and also taking into consideration the fact that there are girls that don't go to school, then we'll begin to make an important move towards improving HPV coverages.
Excellent. So, Dr. Clovis, you actually sort of touched on so many issues, right, which have been really top of mind for a lot of people who are working on HPV vaccination agenda. And you might be aware that Sabin is now leading a global HPV consortium that we have just begun, and which would be launched at Kuala Lumpur in Malaysia on September 5. And this is really exactly the approach that we are aiming to adopt. A lot of things that really said. So the first thing that I heard you say was that vaccination needs to be combined with screening and treatment for communities to start believing that the governments and the public health institutions are truly interested and invested in their holistic health and well-being. And this is exactly the approach that the consortium that Sabin is leading would take, because we are emphasizing all the three pillars of cervical cancer elimination approach. First, human papilloma virus leads to cervical cancer, which actually kills so many women, more than 340,000 women every year now. And it's important to invest in primary prevention, which is vaccination, but it is also equally important to invest in secondary prevention, which is really early screening and treatment of pre-cancerous lesions. So again, the whole emphasis on integration, as you have rightly been stressing. The second thing that I think you again reminded us very well about is this whole need to have a community-centered design of service delivery, where we try and understand what is it that communities need and want, what are their questions, what are their doubts, and then actually respond to all those questions in an authentic manner, so that trust is built and all the questions are appropriately addressed. And finally, this whole value of making a connection with education. And I think that's often forgotten, because this is the first time probably that vaccination community is having to go out and really forge a big time collaboration with education and teachers. And we have seen in many countries that at the time of introduction, that connection is made, but it is soon forgotten. And that is why sustaining HPV vaccine is becoming a big challenge. So a very good reminder of the need for that engagement between health, vaccination, health, and education. You also touched very briefly on out-of-school girls. So would you be able to share with our audience some of your insights about how do we address the vaccination of out-of-school girls? Because in some countries and in some communities, the population of out-of-school girls can be substantial.
With out-of-school girls, I think where we lack has to do with qualitative data. Because what happens is we focus too much on the quantitative data, how many girls are here, how many did this, and so on, that we end up forgetting to characterize the girls we are talking about. Which children exactly are we talking about? It is only when we match quantitative data that gives, that quantifies and locates or maps where these children are. And then the next step, to characterize them, not just by knowing that they don't go to school, but understanding what exactly are they doing at home first. What are the situations surrounding their being at home? What do they do when they're at home? What do the parents think? Because for a girl child that is in school, they may hear about HPV vaccine, but for a child that is at home, it's different. So when the child is at home, where exactly do they go to? So for me, I think the first step to vaccinate children that are out of school is to first do a study. Mm-hmm. Countries should take the initiative, divide their countries into zones based on socioeconomic factors, do small samples, go into those communities, observe, live with them, be with them a month, 2 months, collect good qualitative data, interview. For a second, pretend to know nothing. Just talk with caregivers, the community, mothers, understand perspective. They will give important insights on how to get these children vaccinated. Some of these children belong to a group of girls mentored by elderly women, grandmas, and so on. Without qualitative data, we will never know this kind of information. And the interesting part is there will hardly be one approach to solving this issue. But with this kind of qualitative data, one is able to decide and say, okay, for instance, in Cameroon, the differences are just too wide. You know that, okay, in the northern region, they are more conservative, they are mostly in the house and so on. It means that if I go to vaccinate on these days, I will likely find them and so on. So there's this variation that cuts across different regions in different countries. If we start from there, public health expert will be able to design context-specific approaches that can catch up with these children.
So I think a lot of us continue to say one-size-fits-all approach doesn't work. It shouldn't be prescribed from top or from global level. But I think you have so beautifully explained what a contextual intervention would look like, because it does require a lot of upfront investment in really understanding, but through a sample study, what is it that communities want for any kind of intervention to succeed. And I think I also don't want to lose the point that you earlier made about storytelling. How do we equip everybody to tell a story in a way that touches the hearts of people and actually wins their minds. So both hearts and minds, and so that they come along with us on this public health and vaccination journey. Thank you, Dr. Clovis, for those wonderful insights. It was truly a pleasure talking to you.
The pleasure was all mine. Thank you very much.
Thank you.